Hello, everyone, and welcome back to our mini series on pelvic health. If you're just now joining us, my name is Kelsey Cavadas, and I am a pelvic health occupational therapist. This week, we are diving into common conditions that we can see and can treat. So, we'll go ahead and jump on in. This week, our learning objectives are to describe at least 2 common urinary dysfunctions, 2 common bowel dysfunctions, and also some just general interventions to treat pelvic floor dysfunction. Okay, so we will start with some healthy bladder habits. I usually discuss these at the first follow-up visit or whenever talking about bladder health comes into my plan of care. So typically we would like to see a person void their bladder 5 to 8 times in a 24-hour period. That equates to about every 2 to 3 hours, and we only really want them going 0 to 1 time per night, depending on their age. If I think it's above 70, we're okay maybe with twice. Every void should be at least 8 seconds or longer. That's a good tell. So if you just have a patient count as they're going, 1 Mississippi, 2 Mississippi, 3 Mississippi, just to kind of get an idea. If the void is less than 8 seconds, it could have been a pee that maybe could have waited. So that's a good way to kind of judge for people who are having urinary frequency. So if they go and they're like, well, I hardly even went, it was just a little dribble, that's a pee that could have waited. And going into that, we don't want to do the just in case pee. So I think it's really common, like, oh, I'm running to Target, I better go to the bathroom real quick. And we don't want to be doing that. It just sends mixed signals to our bladder. If our bladder's not actually full and we're trying to go, we're going to start getting those signals when we're half full anyway, and so it just kind of can spiral out of control from there. So 5 to 8 times a day, going every 2 to 3 hours. We want it 8 seconds or longer, and we need to cut out the just in case pee. So some common conditions that we can see, and these are pretty basic, so treating urinary frequency, urgency, urge urinary incontinence, and stress urinary incontinence. Those are ones I see most often. I'll do several evals with these diagnoses throughout the week. So now, what would our interventions be for this? So a lot of times I find that patients are dehydrated, especially my older patients. They're just not getting nearly the hydration that they need. Sometimes they'll tell me, oh, I just take a sip with my morning meds and then I drink tea the rest of the day. Tea is a huge bladder irritant, so it's no surprise that they're having leaks all the time. They have no water in their system, so we kind of math out based on their height and weight how much water they should be getting. Usually they're pretty shocked to find out how much water they should be drinking, so we kind of try to work that into their routine incrementally. So maybe we'll start off with trying to get 1 glass a day, and then the next week we'll bump up to 2 glasses a day, and go from there and try to slowly cut out those bladder irritants, some soda, tea, alcohol, things like that. Depending on what's going on with them, I might put them on timed voids. So some people have urinary frequency where they're running to the bathroom all the time, or they're just having continuous leakage. I might try them on timed voids and maybe start it out. You'll go to the bathroom every hour, then you'll go every hour and a half, and then we'll go every 2 hours. We'll kind of just, depending on the person, figure out what's going on. Conversely, if they're not going enough, so I run into this a lot with my patients who are nurses, they'll go maybe twice in a 12-hour shift because they just don't have time and they stopped getting the urge to go. So now I'm like, you need to set a timer and you need to go every 3 hours, and also you need to check in on your hydration. How much water are you getting? So we have that conversation, and so that's kind of how time voids can fit into the treatment plan. Avoiding diary. So I do like to know what's going on. Sometimes patients will overestimate or underestimate what's actually going on. And so it's a good way to bring awareness to the whole situation. Compliance with this is hit or miss. I usually will ask patients to fill out an actual form that has what I need, or I'll just tell them, keep notes on your phone and email it to me. That way we can at least see what's going on. And so the voiding diary will have what they're eating and drinking and how much, the time of day that they've gone to the bathroom, and how often they're going. Is it a bladder void or a bowel void? Was urge present? And then kind of ranking that urgency. Was there a leak? If there was a leak, what were you doing when the leak occurred? And then just space for any notes from throughout the day. So the next one is urge suppression. So this really comes in handy with urge incontinence and urinary frequency. So the goal there is to decrease that urgency, right? So there's quite a few different things that they can try to do to decrease that sensation, but basically when they get that sirens going, I've got to get to the toilet or else sensation, I want them to pause and take a second. They need to go through some breathing. They need to calm their nervous system, because if they just run to the bathroom, they're more likely to leak, because our pelvic floor and all those muscles they can't hang on when you're sprinting to the bathroom in a panic. So we need to slow down the whole situation. I really like treating urinary frequency and urge incontinence because it's one of the fastest turnarounds. So sometimes I'll give this to them at eval, and then the next time they come see me, they're like, Kelsey, it's fixed, it's better. And I'm like, cool. And if that was their only issue, then maybe that's where we end. It just kind of depends. So some of this happens really fast, and I can always tell who those patients are and how quickly they respond to these things. Next one is pressure management. So this would be more for my stress incontinence patients. So stress incontinence can be caused by a few different things, but one of the main ones is pressure management. So it doesn't matter how strong the pelvic floor is, we can't out-strengthen pressure. So if we're just sending pressure down on the pelvic floor with everything we do because we have poor activation or poor coordination or whatever the cause may be, that's gonna just put so much pressure down on the bladder, and those muscles just can't hold it. So of course you're going to have leaks. So retraining that pressure system. How are the core muscles and the pelvic floor muscles coordinating together? How's our breathing? Are we holding our breath? That sort of thing. So those tend to be my big bladder interventions, among other things, but those are the general ones. So now we will jump over to healthy bowel habits. So pictured here is the Bristol stool chart. I have a version of this in my office that I provide at eval. So the patients can go through it and pick out whatever their typical bowel movement looks like. I would like to see type 3 to 4 is what's considered normal. And we'll also discuss how much effort are they having to give to have a bowel movement. Are they straining a lot? Are they holding their breath? How's their positioning on the toilet? All of those things. I also want to see that my patient can hold on for a bit. Do they have that urgency of the bowels, like you need to get to the toilet or else? Or are they able to suppress that urge a little bit? That's important to know. I run into more urgency issues with the type 6 to 7 stool consistency. And once we do some diet modifications and can get them to a 3 to 4, that tends to go away. I also like to see that my patients can pass a bowel movement shortly after sitting down on the toilet. So are they sitting there for 15, 20 minutes playing on their phone trying to have a bowel movement, or can they feel that urge, go sit down and go get up and go on with their day? So what are their habits? What's their typical situation? And then I also like to see the bowel movements are pain-free. So if we're straining and we're pushing, are we having pain? Are we having a hard time? Do we have hemorrhoids? Things like that. What are our barriers? How can we fix that? And then lastly, I like to know, do they feel like they get a complete empty? So sometimes with constipation or even looser stool, they're sitting there and maybe they went, but they're still feeling like that fullness, or maybe there's more in there. So like to figure out what's going on there for sure. So these are the conditions that I see most often for the bowels. I will get referrals all the time that have some variation of this. So constipation, diarrhea, fecal incontinence, or dyssynergic defecation. So a lot of times the constipation and diarrhea maybe are a side note in the referring provider's note. They're not really something that I ever get a referral specifically for, just something I see a lot. So my pelvic pain patients often are very constipated, and so once we get the constipation figured out, their pelvic pain resolves. So a lot of it's kind of putting on your investigator cap and figuring out what's actually going on, which is one reason at eval I like to ask about every system in the pelvis, regardless of if a symptom is reported or not, because it might be their normal, so they don't think anything's wrong. They think going to the bathroom and having a bowel movement once a week is perfectly fine. So we want to kind of check out what their habits are and what we can tweak to help them feel a little bit better. Fecal incontinence, I do see often. Usually it's that type 7 stool. Patients just can't hold on to it, which anytime you have loose stool, of course that urgency is there. And the worry of a leak is going to happen, which can contribute too. So typically with the looser stool, once we can regulate and get more close to that type 4 bowel movement, the fecal incontinence will resolve. Sometimes it's a strength issue, so I do check all of that out at eval. Dyssynergic defecation, that's another one. Sometimes it is the referring diagnosis and they want that assessed. Usually, at least what I've seen in my practice, which may or may not always be the case, is that they do just have chronic loose stool. And so, of course, those muscles aren't functioning right because they can't sense the pressure of a bowel movement in the rectum. So the body itself just has no idea what's going on. So it doesn't know, should I contract? Should I relax? What do I do? So once we regulate that stool consistency, then it tends to improve and the body's able to figure out what it's supposed to be doing. So biofeedback is helpful here for people who truly do have dyssynergic defecation. We may talk about that a little bit more. Okay, so these are our bowel interventions, and you might notice that they look very similar to the bladder. They have a lot to do with how hydrated we are and what we're eating and drinking. So first and foremost, we want to assess hydration. I find a lot of my constipated patients are very dehydrated, so again, mathing out what is their optimal level of hydration based on their height and weight, and also what's going to fit into their life best. Conversely, I have had a few people with fecal incontinence of loose stool who are drinking over a gallon a day when they're not a very large person and they're not out exerting themselves, so they are getting way too much water and flushing out all their good electrolytes. So it is very beneficial to ask specifically how much water someone is drinking. And then also looking at their diet. So this kind of goes hand in hand with that voiding diary. You want to really break down what are they eating and drinking throughout the day, because the bowels are so directly impacted by what we're eating and drinking. So if we're eating a lot of fast and greasy foods, the bowels are going to reflect that, and they're going to be very poor quality stool, maybe very loose stool, or very constipated, and people are going to have a hard time. So documenting everything, the ins and outs, and identifying possible triggers of loose stool is very beneficial for the voiding diary. So we also want to look at how much fiber they're getting. Our American diet really doesn't support a lot of fiber, so figuring out what's going to work for that client, how we can incorporate more healthy foods, or what's going on. Defecation posture, it's important to look at that. Is their toilet high and their feet are dangling? Are they all slouched over? Even how much time they're spending on the toilet. Are they sitting there for 20 minutes playing on their phone, or are they able to get in, get out, and get on their way? So just looking at their overall setup and how they're doing with that. And then leading into breathing. So a lot of times my patients who are constipated will just be sitting there on the toilet, holding their breath and pushing to no avail, feeling lightheaded, getting red in the face, getting hemorrhoids, things like that. So really want to take a look at their breathing and go over how to breathe properly and how to relax and elongate those pelvic floor muscles to help support a good bowel movement, a good and healthy bowel movement. So now we will go into pelvic organ prolapse. So this kind of gets its whole own category because it's quite a large subject. We're not going to go into it in super detail here, but I at least want to bring awareness that this is something I do treat quite often. I've got a big portion of my caseload dedicated to just this. So the different types are cystocele, rectocele, urethrocoele, uterine prolapse, and rectal prolapse. I guess I must have forgot to put enterocele on there too. But yeah, so several types of prolapse that can happen, and they are pictured here. So you'll see, if I can get my laser pointer, You'll see here is our normal anatomy. So good spacing there, everything's in its little cubby. And then if we go to a cystocele, cystocele is the bladder. So now if you compare our normal to our cystocele, you'll see that the bladder there is encroaching into the vagina there, which can create a little pocket. So it can create incomplete voids of the bladder. So then maybe you empty as much as you can, then you stand up and a bunch comes out. And that's usually something I'll hear as a common complaint and maybe acute to me, like, oh, I should check for cystocele. Uterine prolapse, you'll see here the uterus drops down into the vagina. So now that makes the vagina a lot shorter. So for this one, a lot of times, well, any kind of prolapse with intercourse, usually a patient will say, it feels like he's hitting a wall or something's hitting and it doesn't feel right. But I especially hear it for a uterine prolapse, and just the anatomy has changed so much. So look how small the vagina is now compared to our normal anatomy where there's so much more space. Rectocele is where the rectum pushes into the vagina. And you'll see again, there's this little pocket and how it pushes in there. So stool can actually get trapped in this little pocket and make it more difficult to pass. So some different ways that this can impact our patients. A giveaway for rectocele is a patient might say, well, if I apply pressure to the perineum, I can usually get it out. Or if I insert my finger and apply pressure, I can usually get it out. And sometimes they're embarrassed to disclose this, and I don't figure out that they're splinting until a while later. And I'm like, well, that is a strategy, but if we can get things a little stronger, improve your pressure management, we may be able to fix some of those symptoms. And also their stool consistency. So if they're constipated and they have a rectocele, it's going to be worse. So we want to manage how we're having our bowel movements and what the stool consistency is. So let's talk a little bit about risk factors for pelvic organ prolapse. So menopause is a big one, genetic factors. So do you have conditions that impact collagen and strength in your family? Do a lot of the women in your direct bloodline have pelvic organ prolapse? Obesity is a big one, previous hysterectomy, really any abdominal surgery is going to put you at a higher risk. Parity, have you had children or not? And just general aging, we do get laxity in all of those tissues. So I found this statistic pretty interesting that up to 50% of women will have prolapse upon physical exam, and that's across the board. So studies are finding even women who have not had children are particularly at a higher risk for rectocele because constipation rates are so high. So just because you haven't had children doesn't mean you're not at risk. And so learning to adequately manage our pressures and keep up with a good bowel health is very important. Okay, now let's talk about pelvic organ prolapse causes, treatment, and prevention. So we'll start out with prevention. Unfortunately, I don't get to prevent pelvic organ prolapse very often because usually I only get the referral once there's a problem. But in maybe my new moms that aren't experiencing any heaviness, dragging, any of that, we want to keep it that way. So that's where I really get to educate on prolapse prevention. So picking apart their body mechanics, what does it look like when they scoop up that car seat? Or if they have another toddler, what does it look like when they hoist them up into the car or the cart at the grocery store? What are their body mechanics? How's that going? And then pressure management. So does their lower belly pooch out when they go to lift? Do they hold their breath? Do they do weird twists that impact how our abdomen's functioning? That sort of thing. And then awareness. So we can't really strengthen, we can't relax, we can't do anything if we're not aware of that body part. So many of my clients just are so out of tune with their body and what's actually happening. What does their alignment in their pelvis look like? So just picking apart all of that and bringing more light to it so patients can understand what's going on in their body is a big tool in treatment and prevention. So now what causes pelvic organ prolapse? A lot of things, but the main ones are too much pressure down and maybe some tearing or stretching from delivery, So thinking of those grade 3, 4 tears that really disrupt the tissues in the vaginal area and perineal area certainly don't help anything. But the main one, too much pressure down. So again, looking at their body mechanics, looking at their pressure management system, can they even sense that they are pushing and bearing down through the pelvic floor? Do they know that? And how can we stop that? So paying attention to that is an important factor. So how do we treat pelvic organ prolapse? It's really going to depend on a lot of things, but mostly we want to start by building awareness. I think that is above all the key to being a pelvic health therapist, is just bringing awareness to literally everything. But for pelvic organ prolapse, we want to teach them what it feels like when there's pressure down in the pelvic floor. What are the physical cues that their bodies are doing? So do they notice the pooching of the lower belly? Because that's a big tell, and that's a good way for me to see when a patient is possibly bearing down. We're going to focus on some global strengthening. So when it comes to pelvic organ prolapse, it's not just looking at the pelvic floor muscles. It's how are our glutes firing? Are we quad dominant? Are we upper ab grippers? Am I a ball of tension and my shoulders are way up here and I'm not getting good expansion in my diaphragm? Because as we learned in the anatomy section, if we're not getting good inhales and exhales, we're not getting good function in our pelvic floor. So that brings us to our next one, is pelvic floor function. So what is the coordination of those muscles? Are they firing appropriately with our abdomen? Are they working together well? So just looking at the overall function of those muscles. Do we have quick contractions? Do we have endurance contractions? Are we aware of how to do either of those contractions? And then decreasing chronic pressure. So as we bring more awareness, a client might start to notice, like, when I sit in the car, my pelvic floor muscles, everything feels really pressure, really tight. How do I fix that? And like, well, let's look at your posture. Or if they're lifting, if they're very active people and they're going to the gym and working out all the time and they're lifting, what does that pressure look like? And how many times a day is that happening? Is that downward pressure, a lot of it, for several hours a day? That's something we need to consider. So just looking at the whole picture and treating accordingly. And these are my references for this presentation. And now, if you have any questions, I'd love to hear them. I'm hoping to do a 5th video if I do get any questions on these presentations, that will just kind of go through all of those. So please email them to thepelvic.ot@gmail.com, or feel free to reach out on social media or even submit a contact form on the website. So thank you so much for joining me today. I really appreciate it and had fun working on this presentation. Thanks so much.